Good morning, everyone. Sorry, but we're going to switch over to English now. Apologize for that. Okay, so my name is Jaskirat Gill. I am an emergency medicine trained intensivist in New York. So I like to say that I'm a recovering emergency medicine doctor. I actually 100% work in the ICU now, but I trained in trauma critical care and then cardiothoracic critical care. Today, we're going to spend about 45 minutes talking to you about penetrating neck and thoracic trauma, and then I'll take questions at the very end. I have no conflicts of interest. Today's talk is essentially going to be divided into 4 major parts. The first part, we're going to start off by defining the scope of the problem, so why should we care about this topic? We're then going to talk about some of the injuries that you might see in your department and then what to essentially do about them. Then we're going to start off with some evidence-based concepts that have been up and coming in the literature. We're basically going to focus on 5 major papers. This is by no means an expansive list. There's a lot of literature coming out all the time. But these are going to be papers that are relevant to current resuscitation. And then the last focus is going to be on trauma prevention. So if we think of trauma as a disease process, then really is there something that we can do to prevent it? So we're going to start off by kind of talking about gun violence in the US. This is a major problem for us, as you may have already known through the news, but this is just data from this year. This is up to April. So we've had about 13,000 deaths in the last 4 months. Most of them are in the adolescent population. So between the ages of 12 and 17, we've had about 500 deaths. Of this classification, most are males. And then the real, going back for a second. Clicker? Okay. The really interesting part is about 500 were unintentional, which is just as many as actually the number of teenagers killed. So as you can imagine, this is a huge public health crisis for us. And this is data this just kind of reiterates the information from the CDC. And gun violence-related deaths are essentially the leading cause of death within the age group of 15 and 19. These are young males, these are young minority males, and these are young males of a minority from a certain socioeconomic class. To really bring home the point, this is a summary of data over the last 3 years. So again, as you can see, there's about 40,000 people that died from gun violence. Of these, 500 were killed unintentionally. And then a really terrible statistic is about 500 were killed by legal intervention. So I must say, I didn't really know what the trends were in Sweden before I was invited for this talk. But a quick Google search later turns out this is also an up-and-coming problem in Sweden. So definitely relevant to our discussion this morning. So really, the next part of this PowerPoint is going to be how these cases might present in your emergency department. We're going to start off with neck trauma. So as we already kind of know, the neck is sort of the highway between your head and your thorax. So there's a lot of major neurovascular chains, blood vessels, your spine that goes through this area. So it's a very high density area that's prone to injury. As always, mechanism matters. So within neck trauma, there's blunt, and with blunt trauma, we're really talking about, low mechanism trauma, we're talking about stabbings or any sharp objects, really. These carry about a 10 to 20% risk of injury to a major structure in your neck. And then you have high mechanism trauma, which are, your guns, essentially, that carry a 50% risk of injury. To further sort of understand this, we're going to start off by talking through a case. So this is a young guy that comes in involved in a motor vehicle crash. This is a real case that I had in my first year of fellowship. So he's not wearing a seatbelt, he's intoxicated, he's launched forward into the windshield. And then EMS states that they are unable to get any vital signs on the scene. When they try to talk to him, he's also very intoxicated and not really making a lot of sense. And their ETA is about 15 minutes. The reason I picked this case is because initially it presents as a blunt mechanism, right? It's a motor vehicle crash. But because the gentleman's neck was sort of caught within the windshield, it really did become a penetrating mechanism. Contrary to what I told you on the last slide, sharp objects are a low mechanism trauma. But in this case, because he was launched forward into the windshield, this is a high mechanism trauma. And again, anytime you have that, you have a concern for airway, vascular, esophageal injuries. So before this patient arrives in your department, you kind of have to assume the worst, right? You have to assume that we can't get vitals because he doesn't have any. He's not talking because he can't, because his airway is obstructed. And that because he's so unstable, you kind of want to get your mechanisms in place and you want to have a blood bank ready and your colleagues, your surgical colleagues kind of on their way. So this is how he presented. So one of the core tenets of neck injury is, I don't know if you can see my pointer, maybe it's, yeah, okay. So that little guy over there is part of his platysma. So anytime that you have platysmal violation, you have to worry about a deep injury. He was very lucky because, as you can see, nothing major is actually damaged. But that's not always the case. So if you have a platysmal violation, just something to be mindful of. We were mentioning in the trauma bay that this would have been the world's easiest crike because his trachea is right there. As you can see, his carotid sheath is right under there. And it was sort of pulsating in our faces, which was quite scary. And then just a fancy little parotid gland. Okay. So really, when you are dealing with this, not particularly this patient who was fine, but this kind of story, you have to think about where is the injury, at what level, and that will sort of tell you what might be injured. So you are probably all familiar with this, but we classify the neck into 3 zones, going top to bottom. So zone 3 is essentially from the angle of your mandible to your earlobe. As you can imagine, this is most of your intracranial structures. So your intracranial vasculature, can't really see, okay, intracranial vasculature, your cranial nerves, and then injury to your spinal cord. For these kinds of injuries, if you do have something that needs to be intervened on, your trauma surgeons are probably going to reach out to your neurointerventionalists or your vascular interventionists to come and assist them. Zone 2 is from the angle of the mandible to the cricoid cartilage. This is kind of where the money is at, right? This is where all the major vascular structures are, your esophagus, your trachea, as well as your nerve. This is where the surgeons are really helpful. And then lastly, you have zone 1, which is from the cricoid cartilage all the way down to your clavicles. And now on top of all of your neck structures, you're also starting to think about your mediastinal structures, right? So the apices of your lungs, as well as your arch and your major vessels, if you have somebody that's potentially got a lower neck trauma. Again, something that you want to have your surgeons on board with quickly. So once you've identified where the injury is physically, you also want to be mindful of some of the hard signs of an injury. So this is just a mnemonic, wind, water, wound, waving. So wind is any obvious signs of massive subcutaneous emphysema. Or if you have a wound that's actively leaking air, that's not good. And you're concerned, obviously, for compromised airway. Water would be a pulsatile, an expanding hematoma, or a wound that's just not stopping, right? So massive, you don't have to always have a pulsatile bleed, an arterial bleed. You can have a very profound venous bleed that just doesn't tamponade. And then lastly, if you have any signs of a peripheral neuropathy on the side where your patient's been injured, then again, this is another hard sign of trauma. Even if you may not see any obvious disruption of the neck or the platysma, because maybe they have a C-collar on that was placed incorrectly. If they have a peripheral neuropathy, you're pretty worried. So obviously, if you're worried about the airway, you want to take care of that right off the bat. So this is a picture of actually the place where I trained. We wear pink scrubs, but you always want to have your anesthesiologists at the head of the bed. You always want to attempt intubation from above. So even if you remember the open anatomy of that patient, you still want to intubate them from above, because if you make a hole directly in the trachea, you may potentially disrupt something else. You may make the injury worse. And then you always want to think about the surgical field that you're going through. If you do have an injury, either on direct visualization with your, with your VL or your DL, or you see an obvious injury on the patient, you want to pass your ET tubes cuff past that injury, so that when you, when you bag mask ventilate them, you're not blowing more air into the injured space. Sometimes you may have to main stem bronchus them. And then always, always, always have your crite kit available and hopefully a surgeon at hand. This is another patient from my second year fellowship. So this was a direct transection injury, and everyone, was just reaching to put an ET tube right through that, except he was luckily talking. And so we resisted the urge to intubate through the gaping hole, and we actually intubated from above. So unless you absolutely have to, don't do it. And this is just kind of reiterating the point. Next up, there are obviously a lot of vascular structures going through your neck. So some of the vascular injury management that you're going to see from us, remembering that these are all temporizing measures, right, is manual compression. Manual compression. So it may sound silly, but putting your hand on something that's exsanguinating is going to be the fastest thing you can do. So there's a huge push in trauma called Stop the Bleed. That's mostly for distal extremity trauma, putting on tourniquets and kind of teaching the public how to do that in a safe way, but also applies in the neck, just don't put a tourniquet on it. The other thing that you can do is, if this patient is in your department and you have a handy Foley that's kind of lying around, make sure it's sterile, but stick it into the hole and then blow up the balloon. So a typical Foley, obviously there are variable sizes. You can kind of read it on the flange how much volume it actually requires to fill it up. But a typical Foley will take about 20 to 30 cc's of saline to blow up the balloon. So you just put extra fluid in it, about 50 cc's, and tamponade the bleed that way. And again, this patient or these patients need a surgeon, right? This is just while they're on their way, you're kind of buying them time. So does everyone need a CTA in your department? I don't know how it is in Sweden, but everyone's knee-jerk reaction in America is to get a CTA, because we hate kidneys and we like to give contrast boluses to everyone. So this was a nice little prospective multi-center paper that came out in 2012. So it's a bit dated, but the information still stands, which is essentially, if you have a hard sign, as previously discussed, you need an operation. End of story. Physical exam findings were 87% specific and sensitive for this patient needing the OR. So if you see it, trust it. If you have a soft sign, so this is, a bleed that won't stop, but it's kind of slow and annoying, and you've done all the things, but it just won't go away. The patient has a hoarse voice. or they're coughing a lot. Every time they cough, there's a little bit of blood that comes out. So you suspect that there may be an injury, but it's not immediately apparent. This is the person you want a CTA. And then asymptomatic patients, unless you really want to hold on to them in the department because you have some clinical concern, can be observed and then discharged. Just going back, the CTA itself is about 98 to 100% sensitive and specific for major injuries in the neck. So that's about everything for neck trauma. We're going to be moving on to lower down into the thorax now. So this is a complicated slide, which I'm sure everyone's familiar with from their first day of med school, but your chest has a lot of stuff in it. So you have some protection with your ribs, with your sternum, but obviously that's not going to stand against a ballistic missile. So be aware. We're going to, again, talk about a case. This is actually from the boards. So 22-year-old sustained an injury during a hunting trip. Not something we see in New York City a lot, but I'm assuming you guys do. So on the left arm, the blood pressures were in the 130s over 80s range, heart rate's in the 100s. But you notice that the right radial pulse is very weak, and obviously there's an arrow on exam. Somebody took the time to draw out a sternum, which I think is really cute. But their blood pressure in the right extremity is 90 over 50. So you're suspecting that there's a vascular injury, right? There has to be. You want to immediately activate your blood bank, and then whatever you do, do not pull the arrow out. Okay, so again, where is the injury, right? So even though it looks like the arrow is kind of close to the shoulder, it's still within what we call the cardiac box, right? And anytime you're in the cardiac box, your concern levels should be at max. Your heart rate should be about the same rate as the patient's. So the borders of your cardiac box are your sternal notch, your xiphoid process, and your bilateral midclavicular lines. So if you remember, his was right up here, so he's within the midclavicular line. So at this point, you're very concerned that there is a major blood vessel or cardiac injury potentially. So this is when you reach for your best friend, which is Sparky, in the emergency department, and you want to take a look, right? The first and only view that you care about is the subxiphoid view. It will never be this pretty because there will be about 50 people on this person's chest. But what you're essentially looking for is the presence or absence of a stripe, right? If you have a stripe, you're done. Your diagnosis has been made. Call the surgeon. This patient needs to go to the OR immediately. Even if their vitals are quasi-stable right now, the likelihood that they will remain stable is pretty low. Now, if you don't see a stripe and you have that arrow sticking into the chest, you are still suspecting that there's a great blood vessel injury, but it's perhaps either expanding into the chest, where you can ultrasound that, get a quick chest X-ray, but it's still concerning enough. So even if you don't see something, but you have a clinical concern, it's still relevant. I'll take a question at the end, if that's okay. Oh, I'm sorry. Oh, gosh. Okay. A stripe is a pericardial stripe. So when we look for fluid in the pericardium, apologies. So thank you for that question. Yeah, so you're essentially looking for a black stripe just underneath the pericardium. You can always tell where the... Oh, okay. All right, okay. All right. All right, I should have put in another picture with a stripe in it. All right. Anyway, so let's assume that this patient has blood in the pericardium. Your next question is going to be what are the vital signs, right? So if this patient is quasi-stable and you have time to take them to the operating room, do that. If this patient is crashing in front of you, that's when you start to think about a resuscitative thoracotomy. So overall, the likelihood of survival from a resuscitative thoracotomy is low. But if you're going to do one, you want to do one in a penetrating injury rather than a blunt injury. In blunt mechanisms, your survival is, depending on what kind of literature you read, anywhere between 1 to 2%. You have about 10 minutes from a blunt mechanism, and you have about 15 minutes from penetrating mechanism from loss of vital signs or severe reduction in vital signs. Now, if you have a penetrating mechanism, the type that you want is a cardiac injury, because that subcategory has the highest survival, and that's about 35%. So say you're, reaching for your knife and you're about to do a resuscitative thoracotomy. How should you do it? So this was a prospective RCT of emergency physicians. This is from 21 that basically compared a clamshell approach, which will, if you're not familiar with, there's a slide after this, versus the classic left anterior thoracotomy. The primary endpoint was delivery of the pericardium and clamping of the aorta. So essentially, they trained a couple of emergency physicians and timed them on which approach is faster, assuming that, if you only have to do one side, you may be faster at it. However, there was no difference. It's just as fast to do a clamshell than to do a left anterior thoracotomy. And what's actually even better is when you do a clamshell approach, your risk of injuring something that you don't see is much higher. So if you're going to open a chest, do it this way. So if you're not familiar, this is a typical clamshell approach. In this particular one, they started off with finger thoracostomies, but you don't always have to do that. So ideally, you want to come at it from both sides. You want two people in the room. But you're going across the anterior chest on both sides, and then you're either cutting with your trauma shears or with a Lepschke knife, you're just kind of sawing away at the sternum. That gives you full exposure of the thorax. A word about needle decompression. So if you are out in the field and you have nothing else and you suspect that this patient has a tension pneumothorax and you have to decompress them and you have nothing else, you just have a needle, go for it. If this patient is in your department and you have access to other things, don't even think about it. Oh, this is a bit controversial, I will say, because the ATLS guidelines, so the Advanced Trauma Life Support Guidelines, the most recent one, 10th edition, still recommends that you attempt a needle decompression. But and I have to say this because one of my mentors wrote that guideline, but I think she'll agree with me when I say a lot of so essentially, they needle decompress cadavers and then they look for, did the needle actually make it into the pleural cavity, right? But if you think about it, these cadavers have probably been gone for a while, so they have a lot of loss of muscle mass. So you're not incorporating for the fact that this trauma patient may be a young male who has very thick muscles. It may be a larger habitus person, so the needle doesn't actually make it down into the chest cavity. The one change that the ATLS guidelines did make compared to prior editions was instead of doing the anterior approach, they now want you to go into the mid-clavicular line. Sorry, mid-axillary line. I think this topic has been beaten to death, but I will beat it further. So if you want to decompress somebody's chest, this was a trial essentially that looked at outcomes from pigtails compared to surgical chest drains, so 28 to 32 French, and there was absolutely no difference. Pigtails are just as effective. This is a little bit more nuanced than your prior pigtail versus chest tube discussions you may have heard, because this specifically looked at traumatic hemothorax. So the classic teaching has always been if you have a pneumo, there's no difference, but if you have a hemothorax, you want to go with a Argyle chest drain. That's simply not true. Pigtails are more comfortable as well. This is another paper that looked at outcomes. So say you have a patient that you either put in a pigtail in or you put in a chest tube, a surgical chest tube in. what happens to them sort of down the stream, especially when they come up to my ICU. So if you look at outcomes in terms of failures from the drain, so drain clotting, drain just malfunctioning, drain migration, risk for VATS, all of those were the same in both. The rate of failure on either a surgical chest drain or a 14 French pigtail were exactly the same. And then just a very brief little word on digestive injuries. In short, if you have a polytrauma, don't worry about it. Don't do anything about it. This is not what's killing your patient. What's killing your patient is the airway or the vascular trauma. You can deal with this afterwards. Now, the only caveat to that is if you have massive hematemesis, then obviously you want to secure the airway. And then, figure out where the blood's coming from, either via CTA, if the patient's stable, or you take them directly to the angio suite. But in essence, this is a later down the road kind of problem. So now we're going to switch gears and talk about resuscitation. This is kind of where we'll spend some time talking about the papers that I was telling you about. So this is an older paper. This is from 2012 that sort of compared, this is also, this comes out of ATLS, where the classical teaching was always airway breathing circulation, and that's been contested a few times. And so there was a shift towards, should we just change the acronym and go to CAB, right? Do you always want to do circulation before airway, before breathing? And essentially what they found was this was within the emergency department. And what they found was if your patient is hypotensive and they're in need of an airway, treat that before you intubate them, because the hypotension that's related to RSI meds is only going to make them worse. But just to take home the point, this was in airway injured patients, not all trauma comers, right? So if you have somebody that needs an airway but is also hypotensive, resuscitate before you intubate. This is a study that's actually quite well done. This came out just in February of this year. This looked at, say you're at a point where you need to intubate your patient, and they're quasi-stable, but they're not meeting the eyeball test, right? It's giving you a little bit of panic about reaching for the ET tube. So should we intubate them in the ED or the OR? And this study essentially showed that if you can wait and they're not immediately crashing in front of you, the safest approach is to take them to the OR for the operation that they need and intubate them on the table. Doesn't have to be by anesthesia, can certainly be via or by emergency physicians, but you want to get them to a point where you're not doing something, waiting for stabilization, and then transporting them. The next topic is whole blood, which I don't know if it's a huge topic here in Sweden, but this is all the rave in America. Essentially, should we be using whole blood in trauma? The short answer to that is we don't know yet. There hasn't been a definitive RCT that says whole blood is better than component therapy, at least in civilian populations. A lot of this literature comes out of wars and out of the military literature, where they try to use whole blood as much as possible, because they have young, healthy men or women, who can give their blood in the moment if they needed to. That's why they also get pre-tested sort of before they get deployed. So some of the pros of using whole blood in trauma resuscitation is that it's more physiologic, right? What does that really mean? It means that all of the components that you need are right there. This is more well matched in pH. It's better matched in the electrolyte components. It's better matched in the white cell to platelet ratio. They can be transfused quickly. So instead of doing 1 to 1 to 1, where you're doing 3 separate bags, you can just give them a unit of whole blood and then you're done. It does not lower platelet count as much as component therapy does. And again, a lot of that has to do with the next thing, which is the more transfusions you give, so the more components you're giving, each component has a anticoagulant load that comes with it. So if you give too much, it can actually worsen the coagulopathy that your patient is suffering from, and it also leads to platelet degradation over time. The cons of using whole blood is that it has a shorter shelf life. So if you have it, you kind of have to use it. So where I trained, we used whole blood, or we were starting to use more whole blood, but the shelf life is only about a week. You do have a higher risk for trolley. So this is, again, a little controversial, because if you're only giving 1 unit of whole blood as opposed to 3 components, then, the trolley risk is cumulative, right? The more volume you give, the more trolley you have. However, because transfusion-related acute lung injury, it's okay. Transfusion-related acute lung injury, if you give a lot of volume, you have a lot of inflammatory markers, and the more volume you give, the more third spacing you get, the more capillary bed degradation you have, right? So this is it kind of is a pro and a con, because even though you're giving 1 unit as opposed to 3, the whole blood has leukocytes in it, which has a higher risk of giving you trolley than component therapy. And then, like I said, is it actually better? We don't know. Those trials are 2 of the 3 that were being done are finished, but we haven't seen the results from them yet. This is essentially a feasibility study that was done back last year that looked at, is it even feasible to give pre-hospital whole blood? Is it safe? So what they did was, there were 2 groups. The first group got component therapy in the pre-hospital setting, and then when they came to the hospital, they either got crystalloid or they got a continuation of component therapy. Component therapy is packed red blood cell, FFP, platelet, right? Split into 3. As opposed to the second group that just got whole blood the whole way through. So they got whole blood in the ambulance, and then they got whole blood continued in the hospital. And essentially, the primary outcome was, is it possible? Is it, can you store enough blood? Can you transport enough blood? And the punchline was that it is possible. Even though it was feasible, there was no mortality difference. However, the only one thing that they did notice is in the whole blood group, obviously you had fewer total transfusions, and they matched a little bit better with any TEG derangements. If we don't know what a TEG is, that will be coming up. So essentially, the punchline was, it may not matter in terms of mortality, but it's possible, and that's already a step forward, because one of the big hurdles to whole blood is we can't transport it, we can't store it. And then this was just a review article back in 21. I know a lot of the authors on this paper, so shout out to them. But this was basically just looking at what happens if you give patients whole blood versus fixed ratio versus goal-directed therapy. So whole blood is obviously something we know. Fixed ratio would be 1 to 1 to 1, regardless of what they where they are sort of in their resuscitation. So all the way through, they're getting 1 to 1 to 1. And then goal-directed blood component therapy is through a TEG. So this is thromboelastography, which will go here for a second. If you don't already know, Rebel EM, greatest website ever. This is the most definitive, easy to follow, most comprehensive review on TEGs. So a TEG is essentially, you have like a cup of blood, and there's a needle in it, and it oscillates. Depending on whether a clot is forming or it's in the process of breaking down, the needle will oscillate at a different frequency. So if the blood is clotting, it will oscillate faster because it's more solid. And if it's breaking down, it will oscillate slower because the blood is breaking down. And then and that oscillation is graphed on this way. So where you are, and it always gives you this wine glass appearance, but where you are deranged will affect the length of your wine glass, the height of your wine glass, how narrow the alpha angle is. And then again, depending on where your derangements are, you can give whatever treatment may be necessary. So going back to this paper that kind of looked at those three different ones, what they found was if you have whole blood, great, use it. If you don't have whole blood, what you want to be on the lookout for is early platelet dysfunction and also early loss of fibrinogen. If you don't have fibrinogen, you don't have clot. So what you want to do is, even if you don't have a fancy TEG machine or a fancy ROTEM machine, a ROTEM is just a newer version of TEG. It works slightly differently, but if you don't have any fancy technology, what you want to be really mindful of is early platelets, early FFP, and early cryoprecipitate. The next concept is permissive hypotension, right? So what MAP or systolic blood pressure goal are you targeting when you resuscitate these trauma patients? This was a huge point of contention for many years because obviously more blood pressure, the more better, right? Except it's not true because the higher target, this is the same thing that happened with fluid resuscitation also, right? So if you're pushing for this arbitrarily high MAP of 65 or systolic in the 110s, then these patients are getting more volume. The more volume they get, the more third spacing they have, the more volume ends up in their lungs, the worse their mortality. So this was actually quite a good review article that came out in 21. It looked at 7 different papers that 5 out of 7 were randomized control trials. They were small, but they were still randomized control trials. And what they found was if you are shooting for a systolic target of 90, that is just as good as shooting for an arbitrary MAP of 65. You don't have to shoot for a systolic of 110, which is sort of classically what we get taught in training. And then the biggest thing it proved was it was safe. So even if you were targeting a lower systolic of 90, you still didn't make a lactate. You were still voiding. You were still mentating. So your end organ perfusion was just as intact as a higher goal. The other thing that they found out is compared to the aggressively managed patients, the permissive hypotension patients had less occurrence of the lethal triad. So if you're not familiar with the lethal triad in trauma, it's hypothermia, coagulopathy, and acidosis, right? So those things are higher if you're pushing for this higher target goal where you're giving them cold products that may have been sitting there for a while. They get more acidemic because of product degradation over time. And then lastly, this was a shock trial, so the AVERT RCT that came out back in 2019. So now you resuscitated your patient, you've given them all the whole blood that you possibly could, and they're still hypotensive. So are you reaching for a pressor at that point? As we may already know, Levophed is sort of the norepinephrine is sort of the leading agent for shock in sort of across the board. This trial looked at vasopressin instead. So vasopressin essentially works, as we again probably already know, by 2 mechanisms, right? So you have V1 and V2 receptors. V1 is in your periphery, and V2 are going to act on sort of your neuroendocrine pathways to make more ADH, hold on to more water. All of that is going to increase your MAP. All of that is going to increase your systolic pressure. In this trial, they had 2 arms. The first arm got, they both got the same amount of products initially. The first arm then got, the trial arm, got a bolus dose of vasopressin and then a fixed infusion of 0.04 units per minute for numerous hours, for 7 hours. And then the second arm was the people that just got more product and the control was just saline. So they got a bolus of saline and then a fixed infusion of saline that was running for the next 7 hours. What they were essentially looking for was total products that both arms needed once this therapy was initiated. What they found was the number of packed red blood cells given to both groups were the same. However, the vasopressin group got fewer components. So they got less FFP, they got less platelets, and they got less crystalloid going forward. So if you want to adopt this into your practice, it's a validated way of using a pressor as opposed to crystalloid or blood products for resuscitating your trauma patients. Just a note, they did look at mortality at 30 days, as well as signs of organ dysfunction at the end of 30 days. But this was a pretty sick population, a pretty sick group of patients, so there was no mortality difference. So just to summarize the articles, this is kind of where, we should all be as a group at this point. So always, always, always resuscitate before you intubate. If you can, if your patient can wait to take them to the OR and intubate them there. Use blood, use whole blood if available. Otherwise, remember FFP, platelets, and cryoprecipitate early in your resuscitation. Allow for permissive hypotension with the caveat that if your patient their lactate's not coming down, you're trying to aim for like a 90s target, they're getting worse, they're cold, then you may have to modulate that, but per guidelines, permissive hypotension is a valid approach. And then consider adding vasopressin in your refractory hemorrhagic shock. So now we're going to kind of switch gears and talk about something that's not necessarily, about papers and stuff. This is one of my favorite memes. This was posted in our trauma bay, so all the surgeons were aware of this. So if you remember, at the start of this lecture, I said trauma is a public health crisis, right? And trauma in more recent literature is thought as a disease process, right? So if you have a disease, surely we should be able to do something to prevent it. So where I worked, which is University of Maryland, and at many other hospitals, we have groups called trauma survivors networks. This is just from their Instagram page, but basically this is a peer-led group of people who've been through a traumatic ordeal. So patients out in the community who come to your hospital, get better, are really grateful, and then go out and want to make a change in their community. We reach out to them with our social workers, and we've created this group called Trauma Survivors. And what they do is the next time you're in the hospital and there's a patient in front of you who's from the same neighborhood or who has a similar story to this person who's already been through the system, you can reach out to the Trauma Survivors Network, and they're peer-led interviewees that come in and they talk to your patients, right? It's different when you are talking to them and you're from a different background. You are fortunate enough that you went to medical school. You're fortunate enough that you have a paycheck and that you don't have to live out on the streets. But it's different when it comes to somebody who's been through that trauma and is kind of now on the other side. So this is a yearly sort of appreciation day of Trauma Survivors Day, and it works really well. So a lot of hospitals where I've worked at that have major trauma centers in major cities that have a lot of issues with trauma have these networks built into the program. And then lastly, this is just something I want to highlight. So speaking of trauma survivorship and networking and peer-led things, if you get a chance, if you take nothing away from this PowerPoint, please watch this TED Talk. This is Dr. Robert Gore. He's an EM physician in Brooklyn, and he developed this program called KAVI, which is Kings Against Violence Initiative. He is somebody that was born and brought up in Brooklyn. He's seen traumatic violence in his neighborhood. He's seen members of his own community come into the hospital and go through this massive ordeal, and then go back out into the community and the same thing happens again. So he developed his own trauma survivors network, where he takes a group of people, they go to high schools, they talk to patients, or they talk to family members, they talk to people out into the community who may be seeing all of this happen around them and are suffering silently. And he just kind of creates a safe space where they can all come in, they can talk about things, and then find a way to not give in to the temptation of going out with your friends on a weekend and trying to sell some drugs on the sidewalk. This has worked really well, and this is something that I've been fortunate enough to volunteer with. So if you take nothing away from this PowerPoint, establishing something like this within your own communities, within your own hospitals, especially now that gun violence is rearing its ugly head here as well, is a huge step forward for breaking the cycle. And with that, I will take any questions. I think it's like a little catch box. Oh boy. That's why I didn't want to do it.
You hear me?
Yeah.
Yeah. The thing you mentioned vasopressin.
Yeah.
Would that be the same thing using NORAD or noradrenaline? Or is it?
No,
it's a vasopressin.
Completely different.
Yeah.
Vasopressin is a different pressor compared to norepinephrine or epinephrine.
Yeah.
And so I think the follow-up speaker is going to talk to you about sepsis, so I'm sure you'll hear all about norepinephrine. But across different kinds of shock, hypovolemic, cardiogenic, neurogenic, as well as distributive shock, norepi has sort of been the frontliner for many years, especially for distributive shock, right? So your sepsis and stuff like that. For a very long time, that was being used in trauma as well. So your norepi was being used as a resuscitative pressor. And with the AVERT trial, that kind of, put it to the sidelines and said vasopressin is probably more effective.
Yeah. But did they compare?
Not in this one, but they have previously.
This is really scary. What's your practice on giving calcium if you transfuse a lot?
So it's interesting because, like I said, I work in the cardiothoracic ICU as well as the trauma ICU. Calcium's like our best friend. Yes, I definitely give calcium, especially if I'm using component therapy, because a lot of the mixing agents that go in with your Paxels, your FFP, your platelets, will lower the amount of calcium that you have circulating. The less calcium you have, the less your heart beats. The more calcium you have, the more your heart beats. So by all means, after I'm done with about 3 transfusions of something, I will give them a stick of calcium. And so that's a gram of calcium chloride.
Oh, okay. Which I guess, okay, yeah. I'm single coverage practice, so my chance to do a central line isn't always there. But I need to convert it to the gluconate.
Yeah, exactly. You can just as effectively give them calcium gluconate. You can take a whole lot of Tums and shove it into their mouth, but that's probably not as effective.
Oh, it can happen out in Eastern Washington State.
I bet.
Any other questions?
Anything else?
Hello. You said that back in States you have the blood units, the fixed blood units, 1 + 1 + 1. Here we have it a bit differently, 4 + 4 + 1. Mm-hmm. And sometimes the question is because it's 4 bags for every unit. So do you have any strategy in how you give this medication, this blood? Like do you because we have you have 2 IV access. Mm-hmm. So you start like 1 parallel or is it any strategy in this?
You're saying 1 unit is spread over 4 bags here?
Yes, yeah.
Interesting. What's the volume on each bag? No. Okay.
Then you have peripheral plasma and then thrombocytes. And then 1 bag thrombocytes, which is US size for 4 bags. 4 for 1 instead of a whole 4.
Oh, interesting. Was not familiar with that. If it's concentrated, what amount of volume does it come out to? Okay, that's perfect. That's comparable. So one pack cell is about 340 cc's. So as long as you're giving the same volume, it would be the same kind of dose ultimately that your patient gets.
It's like 4 erythrocytes, 4 plasma, 1 thrombocyte, and is it so? That's the difference I think we have. But I think the concentration or the amount of blood I think is the same.
Yeah. Ultimately, it's about the concentration of pack cells or FFP or platelets that you really want to be mindful about. The more 340 cc's you accumulate, that's where the mortality comes from. So as long as your total volume remains the same, that's okay.
Excuse me.
Wow. I just wonder how is your setting when the trauma patient comes in? How close are you to the ER or to the OR? When you say in the study that you should wait to intubate the patients until they come to the OR.
That's a great question. In this particular study, they were right next door, which obviously impacts mortality all the time. So in the various places that I've worked, so in residency, the hospital that we worked at, the emergency room and the trauma bay was on one floor, and the ORs were on the next floor. In fellowship, where the big trauma center that I worked at, the whole building is trauma. So your trauma ICU, your trauma OR, trauma anesthesia, trauma blood bank, trauma CT, everything is trauma. But that's because it's Baltimore, and if I said this last night, if anyone watches The Wire, that's essentially what working in Baltimore is like.
So would you say that study would be applicable just to high trauma care units?
I would say that study is just as applicable to places where you are, ultimately it's your decision, right? It's your patient. So if you're looking at someone that you think can wait to go to the OR, in other words, they're not immediately crashing in front of you. There's no, they're not gurgling from their mouth, and you can wait. But if you have, your OR is in a different hospital, you have to put them in an ambulance just to get them there, then definitely intubate them. Thank you so much.